post-streptococcal glomerulonephritis, or Psgn, primarily affects children aged 2 to 14 years in developing nations. For developed countries, the elderly are more frequently affected and often face a worse clinical prognosis. Clinical onset typically occurs 1 to 3 weeks following a pharyngitis infection. For skin infections, the latency period typically extends from 2 to 6 weeks. The pathogenesis involves nephrogenic antigens such as streptococcal pyrogenic exotoxin B, or SPEB, and nephritis-associated plasmin receptor, or NAPLR. These antigens trigger the formation of circulating immune complexes and activate the alternative complement pathway. Cell-mediated injury and immune deposits lead to a classic nephritic presentation. Patients exhibit hematuria, puria, red blood cell casts, and localized edema. Hypertension and oliguric acute kidney injury, or AKI, are frequent complications. In severe cases, this may present as rapidly progressive glomerulonephritis, or RPGN. Systemic symptoms including headache, malaise, and flank pain due to renal capsule swelling occur in half of all cases. Nephrotic range proteinuria is seen in 5% of children and 20% of adults. Diagnostic labs characteristically show low C3 and depressed CH50 levels while C4 remains normal. Elevated titers of ASO and anti-NAS-B provide evidence of the preceding streptococcal infection. The streptozyme test is positive in 80 to 95% of patients. Other findings can include positive rheumatoid factor in 30 to 40% and circulating immune complexes in 60 to 70%. Renal biopsy demonstrates diffuse endocapillary proliferation and hallmark subepithelial humps. Immunofluorescence reveals granular deposits of IgG, IgM, and C3. Management is primarily supportive, focusing on the control of blood pressure and edema. Dialysis is initiated if severe acute kidney injury or fluid overload develops. Antibiotics should be administered for active infections only. Avoid the use of immunosuppression, even when biopsy reveals the presence of crescents. The prognosis is excellent in children, with most seeing resolution of symptoms within 3 to 6 weeks. Only 3 to 10% of children may have persistent microscopic hematuria or hypertension. Elderly patients face a significantly higher risk of complications. Up to 60% of elderly patients develop AKI, with an increased risk of progressing to end-stage kidney disease.